All right, let's go through the renal system. This is an overview with some specific details on things that are really important. It's not a huge comprehensive presentation, but it is absolutely everything that you will need to know. The anatomy, I've got a picture here. It's not the best one. I apologize, but I did like this one because it has just enough but not too much detail to give you guys an idea of what you need to know. As far as the basics for the renal system, we've got two kidneys. They're exactly the same. The right one sits a little bit lower than the left one. But as you can see, you've got them up here. They've got ureters. Each kidney has a single ureter that comes down and empties into the bladder. You can see the adrenal glands up here sitting on top of each one of the kidneys. The components of the kidneys are shown here down at the bottom. What's really important to know out of all of this is that you have what's called a lobe, and it's composed of one of these little pyramids, kind of remind me of candy corn, and they are the structural unit of the kidney. There's about 14 to 18 of them per kidney, and the nephrons, which we'll see in the next slide, they kind of bridge over into these two areas from the medulla, which is the inner side of the pyramid, and then the cortex here. The nephron is considered the functional unit of the kidney, and there are well over 1 million of them per kidney. There's 3 different kinds. It's not all that important to know, but there are 3 different kinds: cortical, midcortical, and juxtamedullary. If you look over here, it's not totally obvious in here, but there's a little line drawn here, and this is what I was just mentioning, where part of it's in the cortex and the other part is in the medulla. So let's just go through this. The kidneys receive 20 to 25% of all of the cardiac output, so they get filtered right through here. This is called the glomerulus, and it's a little pile of capillaries shoved into what's called Bowman's capsule or Bowman's space. And here, electrolytes and other organic molecules, small ones, are filtered through. In a healthy glomerulus, proteins do not come through here. They're way too big to get through the glomerular filter. Here you have the juxtaglomerular apparatus. This controls renal blood flow, glomerular filtration, and renin secretion. Erythropoietin, or EPO, is also released. It's released in response to hypoxemia. So when we have low oxygen levels, the EPO gets released so that we start producing more RBCs to help bring up our delivery of oxygen to our tissues. The proximal tubule, which is the next that follows, this is responsible for the resorption of ions and secretion of hydrogen and foreign substances. I got a typo there on the loop of Henle. Ignore my P. That's supposed to be an O. The loop of Henle is responsible for concentration of urine, and the distal tubule is responsible for both reabsorption and secretion of ions, solutes, and some drugs. The collecting duct is responsible for resorption of water, ions, ammonia, and the final concentration of urine. Both the distal tubule and the collecting duct require the antidiuretic hormone in order for these processes to go. So these are the only 2 that require the ADH, and that's important to know. So let's put this all together. We remember the renin-angiotensin-aldosterone system, right? So we've got this guy playing basketball at the top. It's 90 degrees outside. He's not drinking water or Gatorade like he should be. So he's sweating. He's losing a lot of fluid. So his blood pressure decreases, right? And when his blood pressure decreases, renin's released by the juxtaglomerular apparatus. And this, in turn, causes angiotensin 1 secretion. So we're just following the circle down over here, right? So after that, it's converted to angiotensin 2. We have the angiotensin converting enzyme, where'd my arrow go, released by the lungs here. And we have angiotensin 2 then, angiotensin 1 converted to angiotensin 2. This leads to reabsorption of water and aldosterone released from the adrenal gland down here, ends up leading to the retention of sodium and the release of potassium, which further leads to the retention of water because of the retention of sodium. So the angiotensin converting enzyme inhibitors and our angiotensin receptor blockers, our ACEs and our ARBs, these are the preferred medications for renal patients. So they're going to disrupt this whole system so we're not hanging on to water. We're letting it go to help reduce our blood pressure. Remember our natriuretic peptides? So these are released from, they're stimulated to be released when our heart is stretched too much from the fluid. So when we have an excess of fluid from excess either volume overload or our pressures, we have, or both usually, the natriuretic peptides are released, and that ends up inhibiting this whole system. So ultimately, what does it do? It leads to the excretion of sodium and water. So these are our natural natriuretic peptides that do something similar to the ACEs and ARBs. They don't act in the exact same spot, but the outcome is the same, where we're going to inhibit the retention of the water and sodium because we do not want to increase our blood pressure. The details of what goes on specifically at each area of the nephron as far as secretion and reabsorption, it's detailed here. You've got all of your ions, foreign substances, glucose here in the proximal tubule, and going on down the line you can see. This is not something that you need to memorize, but it helps give you an understanding of each one of the areas and what's going on as it runs through there. What's important to know is that urea is important in the concentration of urine. Urea is a product of protein metabolism. If we have low protein due to some type of malnutrition, the urine cannot be maximally concentrated. And this comes down to the simple basics of oncotic pressure. So if we don't have the urea in our serum, to pull the water back out, we're going to lose some of it. And so that makes it difficult to concentrate the urine. When we start talking about how we assess the function of our kidneys, we're going to look at some lab values and some terminology that helps us understand a little bit better. So glomerular filtration rate, or GFR, this is the rate at which our fluid gets filtrated through the glomerulus, right, through our capillaries. And it's affected by oncotic and hydrostatic pressures, which you guys learned back with way back in the beginning in cellular biology, and then also learning through fluids and electrolytes how things work with oncotic pressures. And it's also affected by any type of intrarenal damage, and we'll talk about that in a couple slides. Significant damage, though, will cause water retention. So that is important to know, that if we're not able to filter through our water, we're going to hang on to it. So we're going to end up in a state of hypervolemia. And this is why patients with renal damage end up having hypertension. It's a volume issue. Creatinine clearance, the most accurate indicator of renal function. This is a lab value that we look for. Creatinine is a substance that is produced by the muscle, so it's something that is constantly, it's not for one reason or the other, but it is constantly and steadily released by muscle into the serum. And because it's so constant, it's a great way to measure the function of the glomerulus and see what our filtration rate is. The normal rate for creatinine clearance is 90 to 120 milliliters per minute. As we age, with everything in our body, it slows down, right? Things aren't working as well as they should. It will slow down. So in your elderly patient population, you'll see something lower, but it can be considered normal. As I'm constantly telling you guys, trend, trend, trend. One number doesn't mean anything in most cases. So if you see something that's lower, look at what their last ones were. This is something that we'll monitor over time to see if they actually have some renal damage going on, or this is just something that's steadily decreasing due to age. Plasma creatinine, this is the best measure of a chronic renal failure because it takes a longer time, 7 to 10 days, for the serum creatinine. So this isn't clearance, this isn't what's being filtered through, but just the actual level of creatinine. It does stabilize as the GFR declines. So your normal is 0.7 to 1.2. So if you see something higher than that, there is something abnormal going on. It may represent a chronic state of renal failure. One of the things that you do have to know, though, you have to assess the big picture because there are certain times, like in trauma, where somebody has severe muscle breakdown and they got in a car accident, they sliced open their leg, something that's going to actually cause muscle damage. Also, rhabdomyolysis, this is something that we see with elderly patients that fall down and they've been laying on the floor for a long time. Laying down on their muscles actually ends up with muscle degradation and breakdown. So you'll see an elevation of creatinine in a situation like that. Blood urea nitrogen. So the urea nitrogen is a product of protein metabolism, and this is another way that we can measure GFR, as it's also filtered by the glomerulus. It rises in certain states, whether they're acute or chronic, to indicate renal dysfunction. Dehydration, so the lack of water, somebody's vomiting, diarrhea, and altered protein intake or protein catabolism can also cause changes of the blood urea nitrogen, as it is a product of protein metabolism. If you don't have enough protein, you're going to have less urea nitrogen. If you have states of dehydration, you'll be more concentrated, so it may go up. The normal for this is 10 to 20 milligrams per deciliter. This is a pretty busy picture, and I understand that. It is great though. I like this one because you're going to get a urine sample, do a urinalysis, and look at the things over here and try and understand why the results are what they are. So bacteria in the urine, a urinary tract infection is going to raise the pH. So that's something that we look at. Cloudiness, turbidity, as we call it, whether it's clear or cloudy. It can also indicate some type of pathogen in their byproduct. When we start looking at larger things in there, like bacteria, presence of bacteria, presence of white blood cells, crystals, fats, these are things that are going to help us to understand renal function or infection. Going down into the chemistry of it, you have certain things that we look for in states, diabetic states, where we have ketones and glucose. This isn't necessarily renal function. This is something that will end up spilling into the urine, as we call it, spilling. You'll hear a lot of times protein spilling, ketones, glucose. And these are issues that we have with our diabetic patients that are poorly controlled. Going on down to the lab values at the bottom, my arrow is just not behaving today, it doesn't want to move. This is where we're going to see the values we just talked about. So the blood urea nitrogen, creatinine, cystatin C is something else that can be measured. It's a pretty constant protein. I don't ever see it in practice. We really just do the BUN and creat, as people call it. They just call it creat. You'll hear it, affectionately nicknamed that. And then potassium for sure. So we're going to have really high serum potassium levels if our kidneys are not functioning appropriately. And for documentation purposes, when we are documenting any type of issues with renal function, we look at urine production. So on the right, you'll see some terminology here. Anuria is lack of producing any urine at all. So somebody in complete renal failure would be anuric. We have oliguric, so this is decreased urine output, and it could be for a whole number of reasons. It may just be that the patient's dehydrated. We have polyuria. This is something that we talked about when we were talking about our diabetes insipidus. Dysuria is pain with urination. You'll often see this with urinary tract infections. And hematuria, there's blood in the urine. It could be for a number of reasons. The bladder very easily bleeds. It's very well perfused with blood. Proteinuria, this is something that we'll see. This is something we'll see with severe kidney damage, and sometimes even with our diabetics, this is common. Glucosuria, in states of hyperglycemia, we'll have glucose spilling into the urine. And ketonuria are ketones in the urine that we'll see when we're in states of like DKA, where we're breaking down and metabolizing fats for energy. We have different types of renal failure. It can be pre-renal, intra-renal, and post-renal. So pre-renal is basically anything that happens before it gets to the kidneys. So we have a trauma patient that's bleeding out. We have somebody in sepsis and severe shock. Something's going on that's not getting blood to our kidneys. Our kidneys are failing because they're being starved of nice oxygenated blood. So it happens before it gets to the renal system, and that's why it's called pre-renal. So for some reason we have low urinary output, we have abnormal UA, we have abnormal creat, abnormal BUN. The kidneys are just not working right. But the problem is something that happened before we ever got to the kidneys. They're just being starved of what they need to do their job. A decrease in serum protein. This will cause a decrease in plasma oncotic pressures, resulting in an increased GFR. Okay, so this is back to our basics when we start talking about oncotic pressures. If we don't have enough protein to hang on to the fluid in our arterial system, then we're going to lose water. And so what happens is we end up filtering more. So the GFR increases. And then the opposite happens if we have very concentrated blood, high protein in our blood, high RBCs, something that's making our blood more concentrated. We're going to be hanging on to more of that fluid, and then our GFR will decrease. When we talk about intrarenal damage, this is damage to the actual kidney. So the kidney is damaged. It's not something that happened before the kidney, but within the kidney, it could be trauma related. It could be an infection causing inflammation to the tissues, the renal tissues that are not working. It could be toxins. It could be other types of drugs that patients are taking. They may overdose on something. The infectious process, we'll talk about pyelonephritis in a minute. Or we can have a reduced blood supply within the kidney. So these are things that are happening in the kidney. For example, you may have renal transplant, right? We talked about rejection, we talked about autoimmune issues going on, and so those types of things can happen within the kidney, damaging it. And then we have post-renal issues. So these are obstruction issues. Something's going on, blocking the ureter. It could be a whole number of reasons. It could be kidney stone, which we'll talk about a little bit later on. It could be prostatitis, so either an infection of the prostate, or it could be hypertrophy of the prostate, which we'll talk about. These are things that completely are just blocking it. So what happens? You have fluid backs up. The kidneys just can't drain. And when that happens, it stresses the kidneys and you end up in renal failure, and it's a post-renal issue. So how do we treat each of these, right? So you have a pre-renal condition because this patient is severely hypovolemic, they're in shock. You're going to give these patients fluids, you're going to put them on vasopressors, you're just going to increase the blood supply to the kidneys for whatever reason it's disrupted. Intrarenal, this is a little bit trickier. You've got damage to your kidney, and it could be a whole bunch of different reasons. But let's say you have a pyelonephritis, that's an inflammation and infection in the kidney. You're going to treat it with antibiotics. If it's a transplant rejection, you're just going to have to take that kidney out. Thankfully, we have 2 of them, right? Depending on the toxin or the drug, if there's an antidote for it, that would be great. Quite often what we do is we just give IV fluids to flush it out. But you have to treat the cause of it. And sometimes the cause is just not treatable. And then we have to do dialysis on these patients because the kidney is just completely shot. Post-renal, that's like one of the easiest things to fix. I mean, pre-renal is pretty easy to fix if it's vomiting, dehydration, something like that, right? Give the patient fluids. But post-renal, if this is some type of obstruction, we just put a Foley catheter in. If it's something like BPH, the benign prostatic hypertrophy, which we'll get to. So I guess I say it's an easy fix. It's not. You'll hear of something called a Coude catheter. So it's a Foley catheter that's really kind of stiff and it's a little hook-shaped on the end. That really helps kind of push it through there. It's not very comfortable at all for the patient. We use a lot of lidocaine lubrication that we'll put in the urethra to help kind of numb it. I almost think that just makes us feel better because it really doesn't numb it enough to deal with it. But if we have some type of neurogenic bladder where our nervous system really just isn't allowing us to empty the bladder, these are things that we would do down there. We would put a Foley catheter in. As far as kidney stones, sometimes they have to do a procedure called lithotripsy to break up the stone to get it out of the way. But sometimes that doesn't work. So you can have issues where post-renal ends up leading to some type of intrarenal problem, and it goes on down the line where you'll end up with the backup of fluid and have what's called hydronephrosis because the fluid just stays in the kidney. Nephritic and nephrotic syndromes. This kind of goofs people up and they get the 2 confused. But I like this slide other than the dog drinking the pee at the bottom. That's kind of gross. But the difference between the 2, a nephritic syndrome, and let me clarify this because I think some people got confused about syndromes in prior lectures. A syndrome is not a disease. It's not a disease state. A syndrome is a group of signs and symptoms. So when they're held together in the big picture of things, it's considered a syndrome. So syndromes are caused by a multitude of different things. So in nephritic syndrome, a lot of times what happens here is you have inflammation caused by an infection, such as you'll have a glomerulonephritis. So the glomerulus is inflamed due to infectious reasons, and then it gives you what's called nephritic syndrome. So in nephritic syndrome, the most common thing that you're going to see is Coca-Cola colored urine, and it is that way because it's full of blood. So your urine's going to be brown, you're going to have oliguria, you're not going to be filtering very well, so you're going to have less output. Buerger's disease, okay, so this is a disease, and it's also called IgA nephropathy. This is the most common cause of primary glomerular nephritis, leading to nephritic syndrome. So the big thing, you have protein that does spill out in a nephritic syndrome because you have damage to the glomerulus. However, you most definitely kind of like the key factor is that Coca-Cola urine because of the hematuria. In contrast, you have nephrotic syndrome. This does not have hematuria. So this is not you don't have blood in your urine, but you have a ton of protein. So these patients are losing a ton of protein. It can occur for a number of reasons, in lupus, amyloidosis, which is super high protein, serum protein levels, diabetes, and other chronic conditions. But in here, this patient's going to have hypoalbuminemia, which is over here. So they're going to have really low protein in their blood. So what happens? We lose a lot of fluid, right? From our vascular space into our interstitial space because of our super low oncotic pressures in our serum. So it's going to leak out into the third space. And so in nephrotic syndrome, these people are going to have peripheral edema. And they're going to have a ton of protein in their urine. And our liver is going to respond by going, oh my gosh, we don't have enough protein in our serum. So what do? The liver starts spitting out a whole bunch of lipoproteins. So these patients, you'll also see in their lab work that they have hyperlipidemia. In chronic renal failure, we have patients with a GFR less than 60 for greater than 3 months. And then when that happens, it's basically the definition of chronic renal failure. It's no longer acute renal failure. However, it could have started with an acute injury to the kidney for one reason or another, whether it be trauma or infection, that can cause permanent damage leading to a chronic renal failure. Most often, chronic renal failure is a slow process that happens over time due to diabetes, hypertension, lupus, and other things. You can see here in the picture all of the different risk factors for chronic kidney disease. You have diabetes, high blood pressure, other types of cardiac problems, obesity. There's a family history, so a genetic component to it, tobacco use, and just age. What happens with our chronic renal failure patients is we have a decreased erythropoietin. That's our decreased EPO. And because of this, we end up with decreased RBCs. So quite often, almost always, with our chronic kidney disease patients, they're going to be anemic. And this will be your normal chromic, normocytic anemia. They're going to be normal in color and normal in size. They're just going to be a lot less of them. The treatment for chronic renal failure is we're going to restrict protein and sodium and potassium and phosphate, and we're going to supplement them with vitamin D, erythropoietin, and we're going to manage their hypertension and their dyslipidemia. What seems crazy about this, I know you're looking at it and going, well, how can you just restrict protein? We need protein. It is a very tricky balance, and it's really dependent on the stage of the renal failure. These patients will work closely with a dietitian to talk about the different amounts of protein that they can have in their diet and the different sources of it. So it's definitely a tricky balance. Kidney stones, which I had mentioned, are another issue that we can have with our kidneys. It occurs on one side. It can occur on two. I've never seen two at the same time, but it's generally on one side or the other. So you have these crystallized little rocks. It could be from proteins, other substances, but the most common component of a renal stone is calcium oxalate. And you'll end up, as you can see in the picture, it ends up with an obstruction in the ureter. So fluid cannot come out, and this causes hydronephrosis on the side that it's on. So you can look here and see my arrow. You have that blockage here, here, here. You can be anywhere, and then this kidney will swell, and you'll see that swelling on ultrasound and also on CT. It causes extreme pain. I've never had one. I have seen patients, they can't get comfortable. They're dancing around, hopping around. They're in a whole lot of pain. Women that have had children and then later go on to have a renal stone have told me that it's 10 times more painful than childbirth. So I'm thinking this is crazy, crazy pain. What's really phenomenal to actually watch happen in person is a patient come in with this extreme pain, and we give them IV Toradol. So this is an NSAID, a non-steroidal anti-inflammatory drug. It's you guys are probably aware of it from your pharm class, but it's kind of like ibuprofen. And you would think, oh, what's ibuprofen? What's an NSAID going to do for such extreme pain? I don't know if it's necessarily the anti-inflammatory processes of it, but it makes the pain go away like crazy, and your patients are like, how did you even make that go away so easily? You can give these patients morphine, you can give them Dilaudid, you could give them fentanyl, you can give them all these narcotics, and it really doesn't do much to touch the pain. And the Toradol is just like a miracle drug for these guys. So in order to diagnose it, what we're going to do, we're going to give these guys IV fluids. We're going to try and flush that stone out of there, a lot of back pressure, and push it through. But we're going to send them to CAT scan. We're not going to give them contrast. Contrast is really hard for the kidneys to filter. In any situation, even renal stones aside, any type of situation going on where somebody is going to need a CAT scan and they have renal issues, we are not going to give them contrast. Because it's really damaging to the kidneys. So we're going to do our CT without contrast for these guys. And those stones just show up bright white. They're very easy to see. Moving on to the bladder, down from our kidneys, we've got the anatomy here, comparison of male on the left and the female on the right. Everybody's got a couple ureters. We've got a bladder. The men have a prostate gland, as you can see, and women don't. There's an internal sphincter, external sphincter, and then the urethra. Significance here really is when you go to put in a Foley catheter, know that you don't have to go in very far with women. And some men, you have to use the entire length of the Foley catheter. The normal volume for a bladder is 400 to 600. When there are issues where a person cannot empty their bladder, I've had patients drain out over 1,000, which is pretty crazy. When you start getting that high, though, these patients are at very high risk of rupturing their bladder, which becomes obviously an emergency. The bladder is just a bunch of smooth muscle fibers. It's very flexible. It has a very profuse blood supply, which I mentioned a few minutes ago, so it very easily bleeds for any kind of insult. And this is why somebody with even the most simple type of urinary tract infection will have blood cells in their urine. You may not be able to see it with the naked eye, but on that urinalysis, it'll say that there's RBCs in there. It's very, very fragile. The internal urethral sphincter, this is made up of smooth muscle, and it's involuntary. It sits right at the junction, as you can see, if my arrow wants to work, which it does not. You can see the internal sphincter on both the male and the female. And when the bladder gets to about 250 to 300 mLs in it, that sphincter just relaxes, all on its own. It's completely involuntary by the autonomic nervous system. But that's when we feel like, oh my gosh, I got to go to the bathroom. I'm going to, pee myself. My bladder is full. And in some cases people do, which we'll talk about in a second. But we have our external urethral sphincter, and that's made up of skeletal muscle, which is voluntary. So that's what keeps us from, going to the bathroom when we don't want to. Infections that I had talked about, acute cystitis is the most common outcome of an infected bladder. These people will have cloudy urine, it might be even a little stinky. They're going to have maybe flank pain, which is on the sides, because their kidney might hurt if it's getting the infection's climbing up one of those ureters. We may see hematuria, either frank blood where you can actually see it, or like I said, you'll just have RBCs on the urinalysis when you get it back from the lab. One thing which almost always happens without fail, because it's just so incredibly common, is elderly, especially elderly women, will come in with confusion and aggression. Not quite sure what the correlation is there and how that happens more with age, but people get really concerned believing that, mom or grandma's having a stroke, they're confused, and it's really just a urinary tract infection. And it miraculously, you throw some IV antibiotics at these people, and they come around relatively quickly, where they become more lucid and their mental state returns to baseline. The most common pathogen for a urinary tract infection is E. coli. Because why? Well, really close to our ureter is our anus, and we poop, right? We poop out E. coli. So just way too easy to get that, and this is why, we teach girls at a young age to, when they wipe, to wipe front to back and not back to front, because we want to try and keep that dirty part away from our urethra. Here's the pyelonephritis that I talked about. So we can have a urinary tract infection that then creeps itself up those ureters and gets into our kidneys. It's most common to have it in the kidney interstitium and pelvis. Obviously, it's going to be in the ureter first before it gets up there, but you can see on the right it has pus in that pyramid over there. Urinary incontinence, so that can happen with irritation from a urinary tract infection where the bladder spasms from it, or we just have bladder spasming for neurogenic reasons, diagnosis of overactive bladder. The different types of urinary incontinence are listed there on the left. There's a whole multitude of them. The urge incontinence is a strong, sudden need to void, and you just didn't control it with that external sphincter. Stress urinary incontinence, the coughing, sneezing, very common in women after childbirth, laughing too hard, anything that's really going to put pressure down there. We have a mixed one, which is the urge and the stress urinary incontinence combined. Overflow urinary incontinence. This is a leakage associated with the bladder muscle contractile strength or an outlet obstruction. So this is common. You'll see urinary leakage in a patient that has BPH, the hypertrophy of the prostate, whether due to or not due to cancer. It's just this obstruction ends up with the backflow and buildup of urine in the bladder that ends up causing pressure, and a little bit will leak out through what small area it can get out through the urethra. And then we have functional urinary incontinence, and this can be cognitive, or it can be due to a spinal cord injury. There's a lot of reasons neurologically that the patients have issues with urinary incontinence, and that's called functional urinary incontinence. But here's our BPH that I've mentioned a couple of times. You have that prostate and it hypertrophies. We have all of these excess cells growing. It is something that's pretty common starting after the age of 40. I have no idea why. It makes absolutely no sense. And it's not necessarily cancerous. It can become cancerous, but a lot of times, and that's why it's called benign prostatic hypertrophy. It's not benign in the fact that it does end up causing a lot of problems, but it's not cancerous for the most part. And it can cause constriction of the urethra, as you can see on the right, causing a whole bunch of problems as far as trying to get the urine out of the bladder backing up into the kidneys. So these are some of the symptoms you'll see. They have, dribbling, a very weak urine stream. So many times in your elderly patients, you're going to give them a urinal and they're just going to take forever to pee. You just leave it there, let them try for quite a while, and it'll just be, it'll be a big project for them, but hopefully that they'll get it out. But a lot of times they do retain urine in their bladder. They can get an infection called prostatitis, most common reason in urinary tract infection in men. And they do get sudden urges to urinate, and then they can't. But like I said, with the leaking we just talked about, they will have leaking of urine just because of the back pressure from the bladder being so full. And that's it. It's pretty straightforward. It's a simple system. What's really important to understand is the nephron, how that works, and the lab values that we're going to look for to understand what's going on with our kidneys.